coaching. And it was through his hands, John William Bore in 1943, that the first assessment or survey of the state of healthcare in India happened. And on his recommendations, I believe, even the current matrix of primary health delivery and concepts in India are based on. Professor Reddy, welcome to Kolkata. We wish we had you in person. And sir, the way we will take this session forward is, I think all of us will have something like 5 minutes for our opening thoughts, our opening remarks. And we wish we have a little bit more time at the end of it to come back for some supplementary remarks. And we have a wonderful audience with us. You are missing it over here. And I'm sure some more minutes will be left for the audience to interact. So, Professor Reddy, please, sir.
Thank you very much. It's been a privilege, and certainly the inaugural session has greatly heartened my spirit because of the broad commitment that has been shown by many people to health in the widest of its dimensions. It is very clear that the population level economic growth has a beneficial effect on health and well-being, not only through increased life expectancy and better healthy life expectancy, but also because of the ability to provide better health care to those who need it, to restore health when it is disordered. But we also know that investments in health are going to be very important catalysts and accelerators of economic growth of society. And this bidirectional relationship needs to be recognized and respected. At the individual level, poverty and ill health have a bidirectional relationship, where ill health catapults people into poverty or aggravates poverty if they already are experiencing it. And we also recognize that poverty itself is a major cause for ill health because of the very many pathways it adopts to undermine health. The tripod on which a healthy society rests are a universal health coverage, where an efficient, equitable, and empathetic health system delivers timely, appropriate, accessible, and affordable health services of assured quality to all individuals across their life course. So that is universal health coverage. But that itself is not sufficient. We require multi-sectoral action to steer the social, economic, environmental, and commercial determinants of health towards the goals of a healthy society which enjoys well-being. But we also need active community engagement in people-partnered public health through channels of participatory democracy. And we need to bring all of these together in order to ensure sustainable health and well-being for society. And it's been very clear that health embraces many of the spheres of sustainable development. Indeed, health of the population is the best summative indicator of success in all of the SDG goals put together. But we recognize that when we talk about universal health coverage, we are talking about population coverage, service coverage, and cost coverage. And we need to achieve as much of this as possible through progressive universalization. But this is not possible without adequate financing. And therefore, we really ought to look at a combination of predominantly tax-funded financing supplemented by employer-provided and privately purchased insurance. We recognize that with 90% of our population in the informal sector, we cannot depend upon salary deductions, and therefore contributory social health insurance becomes a very difficult enterprise. And we need substantially tax-funded health programs. As many of the global economists have said, for low and middle-income countries, universal health coverage will be very difficult to achieve without adequate public financing. And that public financing has to be a high level. If we are really talking about 5 to 6% of total health expenditure, then the World Bank and the WHO say that out-of-pocket expenditure should not exceed 15 to 20%. The rest of it should come from public financing or supplementary insurance programs. Yet, whereas we have aimed at 2.5 to 3% of our GDP as public financing, even the last national health accounts of 2017-18 talk of only about 1.35% of the GDP being devoted to health. And we also recognize that there has been some salutary improvement in terms of the reduction of out-of-pocket expenditure, with a claim that it's about 48.5% now. But when we recognize that if we actually take out the capital health expenditure and only focus on the current health expenditure, then it comes to only 55%. And that we have a long way to go, even if we have to move to 20%, but certainly even if we set a goal for 30% of out-of-pocket expenditure, we still have a long way to go. And unfortunately, total health expenditure has actually fallen to 3.3% from about 4.2% in 2004 and 5, which means that many people are foregoing health care. Not only is the government financing is also not able to provide the requisite health services, but even from out-of-pocket expenditure, people are foregoing health care because of affordability barriers. And therefore, there is a plea that collectively as a society, we must ask for greater public financing, both from the central and the state governments. And then, of course, we do need allocative and utilization efficiencies of whatever money is given. More money for health, but also more health for the money. And this is where an emphasis on primary care becomes absolutely important. What we need is basically broadening of our primary health care, both rural and urban, to become comprehensive, continuous, providing chronic and acute care, but also connected care, connected at each level of care, but connected also across the 3 levels of care. And we recognize even in COVID, if we had actually invested more in our urban and rural primary health care, timely recognition, prompt testing, triage and referral to hospitals, more importantly, home care for many people who might not have needed hospitalization, as well as care of long COVID complications, vaccination, all of these are contingent upon very efficient primary care. And even the control of diabetes and cardiovascular disease and hypertension mentioned by Sangeeta Reddy are eminently possible in primary care. So it is on primary care that we must actually emphasize. And for this, we also need a multi-layered, multi-skilled workforce, which is technology enabled. And that is where we must again continue to have adequate investment. And I believe even there, we must try and also ensure to move towards a single payer system with pooled public procurement, which actually reduces the cost, like the Tamil Nadu Medical Systems Corporation's method of procuring drugs. So even for the money that is available, we ought to be able to get better efficiency gains. And therefore, planning a proper healthcare system is going to be important, but we cannot stop short with healthcare. We have to certainly act on the social determinants of health, as well as ensure active community engagement if we really want to reap the benefits of a healthy society over time. I would like to conclude at this point, and I'll wait for questions subsequently. Thank you.
Dr. Reddy, thanks a lot. You've raised at least 7 very cardinal points. I think that could be a seminar in itself. But there are some very important aspects which I'm sure we will find time to come back to. With that, Dr. Reddy touched upon quite a few times, Madam Gupta, on various modes of health insurance, etc. If memory serves me right, at this point of time, about 8% of India is covered by the low-cost government schemes. Roughly 8% of India is covered by your regular paying health insurance. And Ayushman Bharat, etc., attempts to cover around 35%. So which actually does not say anything for the remaining 50%, the half of 130 million people, that how does the insurance sector, are you struggling to penetrate more and deeper into the population because I think it was a leap of faith when Rajiv Gandhi pushed Mediclaim and health insurance in 1986. In fact, hearing Madam Reddy speak over there, Apollo hospitals actually started before the inception of health insurance in India. It predated the history of health insurance by 3 years. So how do you look at it? Because we still do not have, the waters are still not yet charted for how the insurance coverage for the remaining 50% of the country is being planned.
When you talk about healthcare, and one, really, insurance is a very important part of it, all the healthcare and everything. When one falls sick, it is the only time. Normally, insurance is the last expenses one budgets for in a normal budget a person has. It is only when one falls sick and one goes to the hospital, then one realizes how important health insurance is to a person. The bills, they just mount by leaps and bounds. You are there more than the health you look at every day, what your mounting bills are, which is very, very important. So how important health insurance is was felt by this COVID pandemic especially, where we had thousands of people going and, bills were going into lakhs of rupees with all the injections and all what was being dealt out to people. So we, as the insurance, the government has come out with various insurance schemes for the poor, Ayushman Bharat, there's another one scheme, Pradhan Mantri Jan Arogya Setu, but these are for the lower ones. But even in these villages and in the states, nobody comes forward to register it themselves in these insurance schemes, which covers up to 5 lakh as a floater basis to all the families. But insurance is very much required, and how important it is, and we are trying our best. The government is trying, we as public and private sector insurance companies are also trying to get in more folds, because when we have a larger base, the penetration is only 0.29 of our GDP, insurance coverage, health insurance coverage. The more people we have, the more the premiums are less, because you have larger number of people as a base. But, there are very few who take it, and then one is also prohibited at a huge premium, which are, health insurance premium. When you go to take it, you feel, oh my God, the premium is very high. But this is because, the number of people insured, our premiums are based on studies like, how much of masses we are covering, and on that calculations and the particular type of masses which we have. So depending on that, the premium is there. And when our large mass is there, our premium rates will be lower. So it is very important, and we are trying our best to advertise through the government schemes, everything, to make insurance a very important part of our daily lives that each and every individual should have.
Ma'am, thank you for your initial thoughts. I think we will have a few more aspects of health insurance to cover. When you said that it is 0.29% of the GDP, I believe that 80% of the health insurance kitty is covered from 4 of the 30 states of India, which is Andhra, Karnataka, Maharashtra, and probably Telangana. The rest of the 26 states accounts for 19 to 20% of the entire state insurance coverage. Having said that, we have amongst us and joined us online is Mr. Nigam. Mr. Nigam, are you with us? Can you hear us, sir?
Yeah, I'm very much there.
Mr. Nigam, welcome. Welcome to the symposium, Mr. Nigam. Mr. Nigam had the enviable job of gainfully leading Bengal through the pandemic, and he has been a constant source of both counseling and help whenever required. And not only that, we just spoke about the 4 states and the 26 states. We happen to be sitting in a state at this point of time which has been the only state in the country which has worked towards the aspiration of an universal healthcare program through its healthcare schemes. And Bengal's health insurance is now made available to something like 7 out of 10 crore of its population. It's a daunting task. It is marred by a lot of ups and downs. And who better than Mr. Nigam to tell us that how Bengal is working its way through its ideas about health insurance and state health coverage. Sir, the time is yours.
Thank you, Dr. Sarkar. It's a pleasure to be a part of today's symposium, and with health being a forefront, it is a right time to discuss what is happening, what are the issues that we really feel as a health administrators. So there are times when the entire disruption happens. The biggest, coming from a technology field, either the biggest technological development which we saw, most of things developed in this world was after the Second World War, because a lot of innovations went into it and a lot of technologies which were developed later on took us to the next higher level of our human society's advancement. Same way COVID, if you look at the COVID, it has brought back it was a kind of a world war which was happened at a different dimensions. Maybe the war was against us, something minuscule which still we are in a process of learning, but the entire disruption has happened both in the intellectual ideas about the public health as well as both in the terms of intellectual ideas about the public health as well as the technologies and how we are going to look at our public health issues in particular. Now, if we look at it, how the government is functioning and how we are looking at it, is that there is a lot of new schemes which are coming up. At the lowest level, when we talk about it, you find that the rural area, there used to be sub-centers. Now they have been rechristened with the term called health and wellness center, which are not only offering you something kind of a communicable disease, some tika, some kind of doses and all, but we are looking at it, that sector as a holistic, where all kind of even the non-communicable diseases are being provided. We are increasing their number. In Bengal, we call them Superspecialty. We were having it 10,000 such centers in our state. Now they are now being increased to 15,000. So for every 10 to 15,000 population, there is going to be a clinic where a person can approach for the initial system, for the initial screening, and get the treatment done and the next tires of it. But how are we going to empower it? That's a big question that comes up, and here the role of technology comes. And now when we look at it, this entire gamut, you have a lowest level Superspecialty or the health and wellness center. On the top of that, you have PHCs, block primary health centers, Superspecialty hospitals, and all those big things are there. But what happens that, being so well connected, most of the places in Bengal seeing a very rapid pace of urbanization, roads are getting better. There is a need that you connect this entire system in one way and build up an intelligent layer. What we call today, we are looking at in healthcare as a healthcare where you are providing a doctor, you want a physical presence of a doctor, physical presence of a nurse, physical presence of machine, only then my facilities can be made available. Now, taking this to in every village, every remote corner, creating a super specialty kind of facilities is a dream come true, and it will never happen. So what is a need for an R which we are working on is building up an innate smartness in the system. Now here the majority of things like National Digital Health Mission is coming in handy. The telemedicine apps are coming in handy. The connection of huge integrated health system development program that we taking up now, where we want to map every facility with every kind of equipment, and they are usable across wherever technologically permissible, whether it can be used or not. This is one of the biggest challenges, that unless or until you build up smartness in your system, you can't take it forward, the challenges that you have. Today in Bengal, sir, there is a population size of 10 crore plus. No matter how much inputs you make, unless until you share your resources optimally and build up smarter, it becomes very difficult. Dr. Sarkar pointed about a very interesting scheme in the West Bengal. We call a Swasthya scheme. It's a dream of our Honorable Chief Minister. We have now universalized the healthcare. There are two major aspects in government. Number one, we have roughly 85,000 beds in government sector. Treatment of every disease in government hospital is free of cost. In 2016, the government adopted a policy of free healthcare. So if you walk into my best of the healthcare facilities and you want certain operations to done, they are all done free of cost. It does cost for a budget, but the state is providing that kind of budgetary support to run such facilities. Apart from that, what we are saying that alone the government effort cannot be all to provide a proper healthcare to everyone. So that's why we have come up with the scheme of Swasthya, where every family in West Bengal is eligible for a government-sponsored care up to rupees 5 lakh per year in private hospitals inclusive also. What does that mean? Suppose my quality of life goes off in a remote area and I want the only solution left is to keep me mobile by providing a knee replacement. Even that is also permissible under the scheme and we are providing it. So now when we say that the government is totally committed for providing the all kind of solutions so the citizens' life are taken care of in the majority of the cases. Now where does a role come from for everyone? Is that with such kind of massive expenditures are happening, it is also very essential that all the stakeholders, whether it's in the government, whether it's in the private, whether it's an administrator, whether it's people who are working with us, every stakeholder has to look for an efficiency. Because once you commit to such kind of commitment, you cannot be looking at one side of the story alone. That's what we have a regular discussion with our medical fraternity, with our hospital partners and everyone, so that you just talk to everyone. Now we are going to corporatize even this entire our healthcare, the corporation which runs. We are going to bring in further efficiencies. We are trying to further put in the efforts. But what we look at it and what my field level experience has been, that these are all will making a huge impact in the developing the capability of a population. See, I was reading one of the literature, one of the prime reason for people not coming out of poverty line in many parts of the world is that hoping at one point of time you undergo a very high level of health expenditures. Now, people who have a money can go and pay anything and get best of the treatment anywhere. But the person who has all starts with the smallest of the treatment, that is your diabetic treatment. Say a lady of 45 years, 50 years in a remote village of West Bengal will not like to go. They may be having a problem, a variety of problems will be coming, but they will not be able to have an access to the facilities. So the challenge of the government and the approach of the government is providing the access to the healthcare. This is one part of it. And from this point of view, both the expenditure in the public health facilities from the lowest tier onwards becomes very important for us. So that is a stress of the government that we will provide and we will reform our entire public health system right from the lowermost tier so that access to the healthcare is ensured. I can treat a person for a kidney replacement at my Superspecialty hospital, but why such condition is coming up to that level is a lot of undiagnosed, untreated things which are happening at the lower ends. So we want to develop the facility right from there up to the top. This is one part. And we also want to draw a partnership with the private sector by providing a universal healthcare insurance scheme to promote an investment by the private sector in the insurance, in investment, so that the more and more beds are created in the facility of this kind of specialized care is also gets into access to the everyone across. Say in a block, a nursing home of 50 bed can be a viable option and providing a variety of treatments. serious treatments can be, if they can be attended. So this is how we look at it, and we are hopeful that with the constant effort of the government, we will be able to make some difference in the life of the people. Thank you.
Thank you, Mr. Nigam. We'll come back to it. I'm sure you have a big job, a big challenge on your hands. With that, we would like to have the inputs from my friend, Mr. Orno Basu. Mr. Nigam mentioned quite a few times about incorporation of technology. And we've had a bit of a love-hate situation with the incorporation of online education during the pandemic, because it also outlined the fact that your internet urban penetration was lingering around 11%, and how people were lamenting at the end of the second wave that the online education did not effectively reach out to the 80% of the educable people. Do you envisage a similar problem with the technology right now? That technology in India is there, it's brilliant, but it happens to be sporadic in its distribution. And what are your thoughts and ideas about making it available and obviously sharper and better?
Thank you, Doctor. And I think very pertinent question in today's day. And I think we are discussing health for inclusive growth. And of course, inclusive growth has to look beyond just increasing productivity or employability. And the traditional ways of looking at poverty reduction is obviously something which is, which has been tried by the Western world, tried a bit by us as well. But I think if you look at the current India, the inequality or the asymmetry needs to come down, because if you look at how inequality is slowing down the economic development, if you look at the top 20% of India, and if their income share grows, it actually slows down the GDP, because they tend to spend less and less of whatever they're earning. And of course, it's vice versa for the bottom 20%. And role of health is becoming far more critical, as we heard some of the other speakers talk about. So I'll probably try and talk about how do you reach scale, and the only way to reach scale is through technology. And I think that's something which many of the earlier speakers were also talking about. And I'll touch upon a few technology areas which can probably help us. I think we heard from the Honorable Secretary that if you look at digitization, the digitization to support interoperability, to support health information being passed, being exchanged in the right way is very, very critical today. And again, these are some, Dr. Shaukar, you were asking about, I'll come to the, access to technology and access to internet at the consumer end later. But let me just talk about what the government or what structurally we need to do to actually have a platform which allows this kind of interoperability. The next one is, how do we look at automation? Healthcare costs have to come down. Again, technology needs to play a big role in taking down the costs through greater automation, whether it is around conversational interfaces, around chatbots. It has to come down. We don't have the right number of trained medical personnel in this country to cater to 1.3 billion people. Whether we look at virtual consultation, telemedicine, home healthcare, these become very critical, as you asked, that if you look at the online education experience, do we have the right infrastructure, technology infrastructure, mobile infrastructure, internet infrastructure to help with virtual consultation, telemedicine, home healthcare? Again, I would say probably that it is only technology which has to come to technology's help. Yes, the costs have to come down. We need better access to internet. You're very correct that probably having 2 kids at home, I can assure you that the education which they would have got in school versus what they're getting online is very different. But when it comes to, access, if you look at, yes, if a patient comes to you and sits in front of you, would it be better? Probably yes. But if you look at how many you can, possibly cater to in a day, how many people can come to Kolkata and come to your chamber in a day, from that access perspective, virtual consultation is, absolutely, something which is the need of the hour. If you look at home healthcare with better IoT devices, better speech-to-text conversations, better AI, we don't have the number of beds that we need for the country. So absolutely we need home healthcare as a, critical part. I think the other thing I would also like to identify here is we need innovation, but we need frugal innovation. We need micro innovation. In trying to go for these big innovations, we can't lose sight of that. And if you look at how we have looked at patient safety, staff safety, we have seen in the last 1 year that we can look at frugal tech innovations to, really help us. Of course, analytics goes without saying, AI-based diagnostics to, again, manage scale. You were talking about the access. Again, it has to be there because the number of trained physicians that we have in the country is woefully short.
Inquisition, you know. So I was thinking that you were having brainwaves to come up with another different court of inquiry that will make us hold our ears and stick our tongues out and go up and down in some full public view. We are the only profession who sometime in February 2017 have had public lashings, you know. I don't think most of the other professions have had the privilege of doing that. But please, for God's sake, don't suggest another court of inquiry. Our hands are full at this point of time. We'll come back to you. Professor Reddy, sir, you've certainly, I think, the Niti Aayog's last paper on the, I can hear two of myself at this point of time. It's a bit flattering, but at the same time a bit distracting. So if you refer to that document, you know, the multidimensional poverty index, which they have done for the states, because multidimensional poverty index was being studied through for a long time. But when Niti Aayog has looked through our 30 states at this point of time, I think barely 6 out of the 30 states achieves the pass marks, you know. And one of it really evaluates Indian states on 3 parameters. One is health, second is education, and third, I think, is the standard of living. So I think these are the 3 parameters where it is assessed. And barely 6 out of 30 states have scraped the pass marks as far as, say, healthcare is concerned. And we are happy that, you know, Bengal just made it. So had Bengal got half a point less, we would have made it to the 2nd division rather than being in the 1st division. So we've just made it into the Niti Aayog thing. We are happy for that. So looking at this fact, that there is still a sweep of disparity as far as primary healthcare indices, etc., in this large country of ours, something like 24 lakh square kilometers, all of it. How do you see? I mean, are we moving in the right direction? And the second short answer from you we expect is, in your vision about enhancing primary health, do you see in the near term that private sector that accounts for about 60% of money turnover in healthcare in India, do you really see a platform, a model where private sector would be gradually incorporated into the primary health programs?
Well, as far as the first question is concerned, I think...
Sir, I think you're on mute. Dr. Reddy, you might be on mute. You might be on mute, sir.
No, I'm not on mute. Can you hear me now?
Are you not?
I'm not.
Dr. Reddy is speaking. Can you please turn him on?
Unless I'm muted by your...
I think you're all right. Probably a little bit of a glitch this side.
Okay. Can you hear me now?
Dr. Reddy, we'll come back to you.
Can you hear?
I think we are here. We are here. Thanks a lot. You are audible, sir. Please.
Okay, thank you. Well, as far as the first question is concerned, I believe it is absolutely important for us to provide additional financing, but with stronger accountability to the states who are having health deficits. We do need to bridge some of the existing health deficits across the country so that the states which are lagged behind should be supported further with financing, but also ensuring that their expenditure is supported to be channeled into the right areas of priority. And I think it's also important for the states to put in more money, because we know that repeatedly they've been asked to provide at least 8% of their state health budgets for health, minimum of that. And most states are lagging behind that. So states will have to step up. And the 15th Finance Commission has actually provided additional resources, including particularly for primary care, to the local bodies, the panchayats and the urban local bodies, the municipalities. So we ought to get them to spend that money much more efficiently for advancing health. And secondly, as far as the private sector is concerned, yes, I think there's a great opportunity provided the private sector becomes part of a cohesive universal health coverage program. Right now, the organized private sector is largely absent in primary care. They ought to ensure that they come in an organized manner to partner the universal health coverage program under the direction of the public sector. They cannot operate independently in a universe of their own. And that is the connectivity that needs to be established with defined deliverables and accountability mechanisms. I've always defined the PPP not as a public-private partnership, but as a partnership for public purpose. And that public purpose should be clearly stated. And finally, let me congratulate West Bengal. While it might have got the first class now, I hope it will gain I hope it will gain a distinction soon.
We just made it by the skin of our teeth. Sir, actually in Spain, there exists a system where private healthcare providers in Spain, they are given block contracts for certain regions. And when they are given block healthcare contracts for certain regions, they are actually responsible right from primary to tertiary care for the healthcare of that n number of people. So it's actually in their interest. It's actually in their interest to provide good quality private care, because if they did not, then the expenses of secondary and tertiary care will increase.
Entirely agreed. That is the so-called capitation fee model, which even the Kaiser Permanente system in the US follows in some states.
Yes.
And if you look at the NHS system, even if you look at the NHS system in UK, the NHS GPs are all private practitioners, but they're
Right.
part of them in which the capitation fee model really works very well.
Right, sir. Right. Thank you, sir. Ma'am, what are the plans of, say, the insurance sector? What are your plans and what are your initiative for reaching out to larger numbers in the coming years?
Yeah, see, we insurance companies have been coming out with various products, like each individual has a different need. It is not the same, like for you it may be different, for somebody else it is different. What sort of a health coverage? We are coming out with different health coverage for all types of people, the young people, the people in the middle age, the people, old age people. We are having different policies for all these people according to the needs. And we try to, come in contact and get them and advertise and get them into the system. Now, another thing, like during Corona, if you see our insurance regulatory body, we come up very quickly with some of the products, like it came out with Corona Kavach and Corona Raksha, very short-term policies. Normally policies are for 1 year, but we came out with this 3.5 months, 6 months, 9 months to cater to everybody at a very small premium. It was hardly in some 400-500 rupees we could cover 2 lakhs, and as soon as in one of the policies, if you are admitted in COVID, the whole money was given at a lump sum. So we are coming out, and the government is also supporting us in this various Ayushman, where we also participate. In various states, we are participating as an insurance partner for medical, and from our side, we are doing everything possible to see that the entire population has to get covered up. This is our intention, and as insurance company, both private sector and public sector, we are trying to cover maximum all the people, whether in the higher strata or the lower, by giving different type of policies to them. Also, one thing which we would like is most of the hospitals should come into this PPN thing, which will help us give cashless services. Now, because the rates are not there, we have a lot of grievances that we go to the hospital and then, there is a lot of deduction.
You're very unkind to hospital with the rates. See, that's why we're afraid.
Actually, if you go to see, our whole health portfolio is bleeding. With the
we are very afraid of the PPN rates.
No, this year, our first and second quarter with the second wave, my claims ratio is 163%, means I have lost 163%. I have given away.
I think in health insurance
it is always that way.
It has always been that.
It has always been that.
Ever since 1986.
It has never been a profitable business for us at all.
It's always been a subsidized sector, has it not?
Yeah, it has. But for not the private sector, okay, we give it. But that is what our health portfolio is, absolutely a bleeding portfolio. With COVID, though, it became more so, 163. So whenever we try to move up the rates, there's a lot of protest around, we have hiked your rate, but we have to also sustain ourselves because we are also a commercial organization, but we try our best to give, subsidize from the other lines of business.
What is
We have given our
what is
best.
your predicted annual growth rate? At what rate do you think the health insurance is growing in India right now?
So especially with this pandemic, our health portfolio has grown a lot. There's been a lot of interest in it, because so far nobody used to take it, but we find that, every strata of society, wherever it is, everybody wants to take insurance. They've at least understood that you go and you get a recovery, which is very, very important when you fall sick. Initially, everybody thought, okay, I'm healthy, I don't need. They used to see this return on investment.
You need to pay a royalty to the Wuhan lab sometimes.
No, not for that. It is
sometimes
something,
later on.
but every individual felt we are healthy, we are happy. Why do we need insurance? Because you're paying something, but you're not recovering something.
No, rumor has it that you are growing at 30% per year. Is that true?
No. This year we are growing at 25%.
25%. So it's not 30% yet.
It will grow slowly and steadily with the new products which we are coming up with.
Wish you all the best, but do increase our rates.
But you also support us, we should have this network so that we can give cashless facility. That is very important to any patient.
Right.
So
I think that's a very important point.
Yeah.
I think that's a very important point. Is Mr. Nigam with us? Is he on the line? See if we can connect back to Mr. Nigam.
Yes, tell me, I was in the midst of a different call. Tell me.
Yeah, I know, sir, knowing how busy you are. Sir, can you just swing your camera down a little bit? Yeah, that'll help.
Tell me.
That'll help. Mr. Nigam, one quick question is, West Bengal has shown higher allocation of the state GDP to health than many other states. Even though I'm sure providing for Swasth Sathi and all the other health schemes is a big challenge right now. But I think of all the first major 10 states of India, our percentage allocation of state budget to health is probably on the higher side. There is a bit of controversy going in the background about health remaining as a state subject or being pushed back into the concurrent list. Do you have any views on that? Do you think that there is a lot of policy overlap or there is a lot of policy obstruction in that matter, or you are happy the way things are? And secondly is, with your experience, how do you see in the future that you are going to attract enough resources for your health schemes to run seamlessly?
Now, I will come with the first thing is regarding it's a constitutional mandate that the health is included in the second schedule of the distribution of the power. Let it be debated where it should be. And being a government officer, I would like to keep my comments reserved as far as in where should it find its entry into. But as far as we are concerned, we have any issues, but generally things are being settled. We have seen that quite a good way we have managed the vaccinations, COVID management, and all those things have been taken care of. So I will keep my comments to that level only, and I will not like to comment. It's a little touchy issue. As far as the financial commitments from the side of the state government are concerned, as of now, let me assure you, Dr. Sarkar, my Swasth Sathi bill has seen a tremendous hike in the last 1 year. But as of now, we have never faced any problem in this regard. The minor hiccups do come in the management of the cash flows and other issues. But as far as the commitment of the state government is concerned, we are fully committed for continuation of the initiatives that the state government is taking. And I will also like to put on this forum, I'm glad to inform you that when I talk about these investments, the huge investments that are flowing in this sector. Someone was discussing about that you have to do the treatment at the right time. I was in my initial opening remarks, I said that it's I can create many facilities where you can think of having a kidney replacement or a high-end kidney treatment. But from where it starts, unless or until you provide a healthcare there, for the government, for the individual, it may be different story. But for the government, it has to beginning from the getting the tap on the disease right at the time of beginning. That is what is the whole focus on non-communicable diseases, which is resulting in. I have been to places in the remotest areas of West Bengal where we are doing a diabetes clinic, where the people have an access to a diabetologist from a Swasthingit, our telemedicine portal. Today, West Bengal is number 2 in terms of usage of telemedicine services. Above us is Andhra, which started much ahead of us. Daily, around 20,000 people are getting benefit from a remote places as a part of OPD clinic using a technology. So the solution lies today is having an access and leveraging the power of technology here. As far as the funding and all, if it is a priority of the government, funds are normally arranged for. Thank you. But again, we have to bring in the efficiency of the money spent. There should not be any repetitions. There should not be cost, has to be optimized. And by leveraging the economies of a scale at which when the government operates, we should be able to bring down the costs. Thank you.
Thank you, sir. Thank you. Thank you, Mr. Nigam. Arnab, you spoke about being frugal with technology innovation the last time. I'm sure being in PwC, you've seen a lot of the innovation, the whole spectrum of it play out in front of your eyes, the unicorns marching in and out, whatever you call them. How do you monitor the activity in the healthcare sector as far as the startup, enthusiasm, development, all these things are concerned?
So I think you obviously mentioned that I think the entire journey of Indian entrepreneurs to become unicorns, I think that has definitely pushed a lot of young minds, bright minds into innovation. They want to do startups. And I think over the last 2 years, I would say a lot of focus has shifted from fintech startups to health tech startups. And I think people are looking at it as a career choice. Bright boys from IITs, bright boys from medical colleges are looking at this as a career choice to go into micro innovation, frugal innovation, because obviously, if you are starting from your garage, as the Silicon Valley had seen, you don't have the kind of money to go in for very large scale innovation. But if you look at innovation in the area of diagnostics, quick diagnostics, small devices help you, diagnose probably diabetes ahead of, what you would normally do. If you look at last mile connectivity, last mile delivery of medicines, if you look at robo assistants, if you look at costs going down for our IoT devices, which are very critical in getting, digital operations into medical, science. If you look at the overall information dissemination that we have had during COVID times, in terms of how you can get block level, district level, borough level information out to people, you would see micro innovation, really flourishing in this country. And I think that's a way forward as we think that how you make it more inclusive, how you make it more available to people. And of course, Mr. Nigam talked about the telemedicine access. So quite a few of those.
Arnab, thank you. We are pressed for time a little bit. Rupali, you are in the presence of Dr. Reddy, you are in the presence of Mr. Nigam, you are in the presence of absolutely the head of national insurance. You had a chance to make 3 wishes from the private sector for the sector to grow and healthcare to reach out more fruitfully. So come out with your main wishes. What do we wish from the policymakers, from the think tank, from the state administration, from the insurance sector?
God, it's a big ask, Kunalda. We need a lot of things, but yes, I think the topmost thing would be that we need to be, as I was saying, the same thoughts. That think of us as people who are organizations who are not thieves and culprits, but we are thinking about everyone, doing our job in our own boundaries as much as we can. And don't think of us as the villain and the culprits, but we are respectable people. Put us into that light. So don't bring in more and more commissions and acts and courts and whip us, but think of us as the most important part of people. When they are ill, we are providing care. So think of us as the right kind of, give us that respect. I think that's
Anything else?
the first.
Anything else?
The second is, I think the health insurance sector, as you were saying, the costing bit of it is not done. It's done in a very, very, I think it is done. I would like to say not done as a corollary, but I know a lot of work has been done in bits and pieces. So the costing is very, very important. It is not done the way we look at costing. And naturally, the rates are being put in just like that. So I think the rates are absolutely, as you requested, ma'am, I'm also requesting the rates needs to be relooked at, and it has to be somewhere where we make money a little bit, and we kind of make sure that the health part of this insurance, which you are saying in loss making part, should be profit making. I would wish that to also happen, so that our rates are kind of acceptable, because of the simple reason that we also want every Indian to be given good quality care. So we want to be part of that drive, part of that movement, that everybody, be it poor, rich, wherever they are, should get good quality care. So please keep us into that mode, keep us into that thought, and we would like to be part of that journey. That would be my wish, Kunal.
Rupali, thank you. As you were speaking, ma'am was smiling, so I think your wishes will very shortly be answered. I just observed her facial expressions and body language as you were making a very impassioned plea out there, Rupali. So I think, let's wait. We may be in for a little bit of luck. So, friends, we've had a wonderful time. And I, for one, I'm sure with all of you, learned a lot from this session, especially the likes of Dr. Reddy, Mr. Nigam, Ma'am Gupta, Arnob, Rupali, all of us together. And with the combination of health and technology, I am sure that if the center of Benares can be decongested, combined healthcare and inclusive growth also has a bright path paved out in front of it. Wish ourselves luck, all the best, and thank you for the opportunity. Thanks.
Thank you.
Before we close the session, I would request ACM Raha, Mr. Anirudh Lahiri, and Dr. Roy to please come to the dais and present mementos to the dignitaries on the dais. And of course, to our speakers online.